Hi, welcome to our live webinar on the next great advance in virtual care. So this is part of our virtual care series. So my name is Ed Marks. I serve as the Chief Digital Officer for Tech Mahindra Health and Life Sciences. And I just want to welcome you today. I'm very excited to have our guest, Dr. Matt Lambert. So Matt and I have a long time relationship, and I won't go into details because he's going to introduce himself and maybe connect some of that. But I'm thrilled to death to have not only one of the foremost physician, executive, technologists, but also my friend on the show. Matt.
Thanks, Ed. Good to see you. Good to be here. Yes, so once again, my name is Matt Lambert. First and foremost, practicing emergency medicine physician. I've been doing that for over 20 years now. I guess I'm giving away my age. And that has been just a remarkable time to be in the emergency department on the front lines during this current challenges that we're having. Also, along the way, took a great interest in technology, healthcare and technology, and policy around that. So over a decade ago, we formed Clinovations, which was a physician consulting group in DC that really focused healthcare technology and delivery. Came around about the time the Meaningful Use Bill and the Affordable Care Act kind of coalesced into another remarkable time in healthcare. And we helped health systems implement, configure, and drive value from their electronic health records. And we did that for health systems from coast to coast, and with Cerner, Epic, Athena, primarily was our area of focus. That Clinovations was acquired by the advisory board, and during the time that I was with the advisory board, that's when Ed and I got to test our friendship in fire as the team at New York City Health and Hospitals, where we put Epic in at the nation's largest public health system. And that was a fantastic experience working with Ed and also with HCI that came through that. And then since leaving the advisory board, I've been continuing my clinical practice and working as the Chief Medical Officer for Curation Health, which really focuses on using technology again to help drive value in their value-based care programs for HCC capture and Medicare Advantage plans. So a long-winded introduction. I apologize for that, Ed, and looking forward to our discussion.
No, it's great. And this is live, and we do live for two reasons. The first and foremost is engagement. So we want you to be engaged with us, and we will be responsive to your questions. So we are looking at your questions, and we will pivot our discussion based on questions. In fact, we had several questions come in ahead of time, which we've incorporated in our script as we move along here. So please interact with us, and we will try to respond to every question that you have. So the live webinar today, or the second reason we do live, is sort of it's fun for us. Something always interesting happens, whether it's a lawnmower or whatever. So we're really divided this thing up into three sections. One is what's the current state, virtual care. We won't spend a whole lot of time on anything that's everyone already knows about. Sort of the evolution. So we're not going to talk a lot about COVID because a lot of people are doing that, and that's great. So we're going to try to nuance our answers, our questions, to hopefully bring in some new information or ideas. So the evolution, and then finally, where are we today in terms of the advancement, like what's coming next, or maybe is already here, and talk about the Health Next platform that we've spent a lot of time alluding to or talking about in previous conversations. So with that, current state, Matt, describe, just to level set us, as we said, we won't spend a lot of time on things that people already know, but just to level set us as we take off into these questions, sort of the current state of virtual care as you see it, both as practicing doc and as our Chief Medical Officer.
Yeah, current state. First of all, exciting, changing almost daily. And also rapidly growing. I mean, just some of the numbers when you have a review of Scott Becker's site talks about 4,000% increase in telehealth visits from March of last year to March of this year. They think we're going to have over 1 billion telehealth visits in 2020. Our friends at NYU, Paul Testa, put out an article in April that says they're up 4,300% in their telehealth visits. Novant, their CMIO, said they went from 200 a year to 12,000 a week. And Ed, we were meeting with Atrium last week, and they talked about their e-visits are up 6,000% from last year. And again, and again, we don't need to talk too much about COVID, but all of this was a pivot to quickly screen for COVID patients or treat COVID patients or provide care in a way that minimized risk from a contagion. But we think this is really opening the opportunity for this to be a more integrated part of care. And also it's knocked down the two remaining barriers that were really keeping us from doing this before. Number one, that's expectations from both patients and providers that they're going to receive and give care through this way. And CMS has done as good a job as you can do responding to this with the reforms around it. Because if the way that we reimbursed for primary care before required some face-to-face elements, they're reimbursing at those regular rates for now, and also that 1135 waiver also allows this to be done over any modality. Now, I think for sure we're going to see that shift to payments will adjust, and the platforms will adjust to more HIPAA compliant platforms. But it's really bowled over the remaining barriers to this. So it's created a lot of opportunity through crisis, as is often the case.
Yeah, so let's talk about, so there's two specific questions, again, that may be a little bit different, and that's what we want to do, is add to the content that's already out there. Yep. And we're going to take the statistic, because they're all about the same, but of my former employer, which, 2% of outpatient visits were virtual. Today, or the high watermark was 80%. Now, based on what you just said, what's the percentage, do you think, using that as a model that, might transfer to others, where do you think we're going to end up with 1 year from now? So if we saw a 4,300%, whatever increase March to March, or the time frame that you cited, and 1 year from now, where do you think that 80% will be? How far will it have gone down?
Yeah, great question. As people get more comfortable in this new environment, both patients and providers, I think we'll see some of this return to brick and mortar care. But I think an estimate is about 40% of this isn't going to go back in the bag. And that's going to be because of efficiency. That's going to be because of, I think, a lot of providers and patients are going to enjoy this experience more. Go ahead, Roman.
Yeah. So I agree with you on the experience. Okay, what about though? So I think the experience is going to what forces that number to stay high, and appropriately so. What about another potential accelerator? But it remains to be seen. I'd love to get your opinion on this, since you practice and do telemedicine as well. Is quality of care. So what do you think? How do you think, is quality going to be improved? Do you miss something doing virtual care?
Yeah, and again, we're pivoting from COVID screening or COVID surveillance, I'll call it, and the current state of a lot of telemedicine services is very retail oriented or episodic. So I think this is going to move into longitudinal care. Getting seeing your traditional health system or your traditional provider just during a new modality. As far as the quality goes, I think for existing patients, which is the vast majority of ambulatory visits, I think it's going to be. I don't think we're going to see any compromise in quality at all. And we've seen the early adopters of this around derm and around behavioral health. I think they've really kind of paved the path there. Yeah. As one of the questions we had before was about critical findings. Truth be told, physicians my age or younger, we rely so much on diagnostic technology to help us, get, instead of listening for that cardiac friction rub, we get an echo, right? And I'm always humbled when I practice medicine in other parts of the world, where I go to Africa or go to Haiti, by how much better those clinicians are at using their eyes and their hands as we are. So I don't think we're going to miss a lot of critical findings. We are going to have a pretty low threshold to convert that to an in-person visit based on the chief complaint: chest pain, shortness of breath. There are certain things that you're just not going to be able to manage under this modality. But I think quality is not going to suffer.
No, I agree with you. That my limited experience, my previous employers, we saw from a digital hospital perspective of virtual care quality increase, and from a RPM, so remote patient monitoring or monitoring patients at home, it was the same. So there was no degradation in quality, and so I think definitely the benefits outweigh the pros outweigh the cons. All right, so that's sort of the current state. So again, we talked about what it is and will it stick. Hopefully there's some new information there with the statistics we were able to share, as well as the clinical quality aspects, which is often not talked about. So let's talk about sort of the evolution. You mentioned, Matt, the acceleration that recently happened. And so let's talk about this. How can virtual care help with health equity. Can virtual care be used as something to help equalize health equity?
Absolutely. And this is a topic of the day for several reasons, not only on outcomes from COVID, but in general. When we think of patients with what they call transportation risk, so someone who is relying on a loved one to get them to the doctor, or relying on public transportation to get them to the doctor, I think delivering care to them at home is going to really help level the playing field there, and via the phone, right? We, I know we talked about this a little bit prior to, and Dr. Raju was talking about really focusing on how to interact around that. I think for people with limited mobility, this is also going to be a very good alternative to take the care to them. I think there's an opportunity with 40 million people currently becoming unemployed. I think there's a real opportunity to create some community outreach associated with this. Of helping elderly ones, or helping those in your community who can't get around as well, or who aren't as facile with technology, helping the young members of the community get out and help provision, so to speak, these folks in their home. We are going to have to make some investments in infrastructure, right, around this. We are going to have to, Wi-Fi is going to have to become, networks are going to have to improve. So that's going to be the challenge from the social equity piece, that we're going to have to make some active investments at a community level in that. But I think there's a real opportunity here to help level the outcomes associated with the determinants of health.
Yeah, like you said, Dr. Raju famously says there is no health equity without social equity. And I remember, even in my experience in Cleveland, we were writing this book called Voices of Innovation, and one of the contributors to that book was actually a professor at Case Western, and she had done some empirical research and studies and found that over 25% of the population in Cleveland, so this was hard for me to believe, but it was research based, and it is, it's a fact. At that time, so this would have been 2 years ago, 25% did not have the capability to do a virtual care. They could do the phone though, the virtual care from the phone, but nothing that required any sort of bandwidth. So you're right, there still needs to be continued investment made in those areas, and we've seen the government respond with some programs, and obviously health systems are doing the same. So I think once you address the social equity, it'll help with the health equity, to Dr. Raju's point.
And I also think, just when we think about RPM, we think about medication adherence. You'd be able to find out who's sticking to the medication plan, and when it would be time to take the medication to them, because that certainly helps increase adherence, and also with food insecurity as well. Yeah. If these folks are struggling with food, take the medicine to the point of care, to the home.
Yeah, and we've seen a lot of very innovative approaches. Geisinger jumps to my mind, Atrium, Novant, many health systems are responding in their communities, and it's really neat to see all the different innovation that takes place, not just from a, like we're talking about, sort of a virtual care point of view, but really practical things to address the social inequities. So so it's really a combination of the two working together that can really change things with our outcomes. Let's switch a little bit to talk about fraud. So fraud obviously is a huge issue today in healthcare, has been for a long time. Anyone will try to take advantage of any sort of loophole they can find. Does that get worse with virtual care, or what do you think about fraud in virtual care?
I don't. Anytime you have a big market shift like this, or you're going to have some bad actors entering into the space. I think I balance that with the current level of fraud that goes on in telehealth now, because to the letter of the law, in order to drop some of these codes on these ambulatory visits, it requires you to document certain elements of your physical exam. And I think as we think about steady state telemedicine, those requirements are going to have to go away, because you're working with an established patient. So I don't think it's going to increase. I think it's going to move a little bit. You can also make the argument that it's probably easier to track. It's going to leave a digital trail for those bad actors who are engaging in this space. So I think those who commit fraud are going to commit fraud either way. And I think it's just something that CMS and the payers will be very vigilant about. And I think it's probably going to be easier to track, done virtually.
All right, we are halfway through. We encourage your questions. We have several questions already, so I do see the questions. I will get to those questions. It's always hard. We keep it 30 minutes because time is so difficult for everyone, And at the same time, it's like, wow, we could go forever because there's some fascinating guests like Dr. Lambert and topics as well. So let me ask you, here's a question that came through, and I'll just get your take on it because I'm sure it's the same as mine. And that is a telephone encounter considered a virtual visit, or does it have to include video?
Yeah, that was my fault for not framing that at the very beginning, because when I say telehealth, what does it mean, right? And when we say telehealth, we're meaning specifically audio visual components associated with it. There's a separate set of CPT codes for phone calls based on the length of the call. The CMS had those rates initially. They actually increased them in April just because so many health systems were pivoting to a telephone call. But when I use the word telehealth, I'm talking about interactive audio-visual communication.
Yeah, and I think when I think back to Dr. Raju, again, not to keep referencing him, but he's a former colleague of ours that we reported up to when he was CEO in New York City, and he's really a leader globally in this sort of topic. But having just the telephone capability, that helps to be an equalizer, because like we were saying, not everyone has the full video capabilities yet. So,
and currently with this waiver, a lot of these visits are occurring on FaceTime. So the new standard for telemedicine for those entering the spaces, you've got to make this as easy as FaceTiming with your grandkids, right? Because that's what they're doing right now in some cases.
So it's really about the user experience. I don't want to jump too far ahead. It's about the experience, making it seamless, making it easy, simple. That's the key to success, long term. So there's a couple other questions around sort of what are the features and functions that are missing today? What do you see happening? So we're headed into sort of like we covered in the first third, sort of the current state. We spent the last couple of minutes talking about the sort of evolution post-COVID or COVID accelerated evolution. Let's talk about, okay, what's next? Okay, we get through the pandemic. There's this heightened awareness, higher utilization. And now what do we do? What are people looking for? So everyone's scrambled for solutions. Give me Facebook, give me Zoom, give me Teams, give me whatever is going to work to get through this. I can create a quick chatbot. I can do a quick triage, all these different things. Now, let's just assume, Matt, things do settle down, like we're seeing the trend settle down, and it's 90 days from now, and we have a chance to take our breath, and that there's still that high level of interest. There's still that a lot of payers that this is the way, the genie's out of the bottle, as the CMS administrator said. So let's make some of those assumptions and be very open with that. So what's sort of lacking today that 90 days or 180 days from now we'd want to see ideally in virtual care?
Yeah, no, it's fantastic. It's again shifting from COVID screening or COVID surveillance and from more retail or episodic care to longitudinal care, really fortifying that long-standing relationship between providers and patients. It is going to, much like we saw the electronic health record market consolidate, we're going to see the focus is going to become on integration. How do I integrate with the electronic health record? It's going to integrate. It's going to be at the enterprise level, not cobbled together with interfaces and a lot of different licenses for different products. It's going to be that longitudinal telemedicine visit integrated with the electronic health record, and that will become a part of care moving on. Then I think that the next, as we get more sophisticated, more integrated, the next step around that is going to be remote patient monitoring for at-risk populations, and whether it be for an elderly and infirm population, CHF, COPD, a part of removing readmissions, or whether it be part of a population health strategy around something that's in a value-based care plan. We're going to see remote patient monitoring that will allow us to identify patients who are going to get in trouble before. And that telemedicine visit can be triggered off of either a patient saying, hey, I need a little higher level of interaction here, or something in the remote patient monitoring may trigger someone on the care management side to actively reach out to the patient. And then eventually, I think we're going to see that this will get into that hospital level of care provided at home. So whether it be a skip the sniff program, whether it be shortening the length of stay for particular diagnoses, or whether it be inpatient level care given from the very beginning with remote patient monitoring, I think we're going to see that's how this is going to grow and expand 90 days and moving forward, really becoming ingrained in the type of care that health systems are presenting today.
Yeah, those are good points, and that's addressing a lot of the questions that are coming through about some of the features and functions. And we'll have time to go one level deeper in a second. And that was the common thing when I worked with my fellow sort of people who were responsible for digital transformation in their organizations, like I was, and talking with peers that had the same sort of job responsibilities or other CIOs. It was a huge conundrum, even before COVID, as we were thinking, as we were already down this path. As we mentioned, it got accelerated, but a lot of the healthcare was already headed this direction. And we're like, okay, how do we manage all this? Because in order to do it, I've got 2 different vendors doing our video visits, multiple vendors doing RPM because they only focus on one disease state like diabetes. And then obviously most patients have multiple issues that they're dealing with. So it's not just one. And then we had a lot of aspirations, or we were doing digital hospital, EICU already, but a lot of aspirations. But we kind of missed, like you were describing, that whole post-acute care, long-term care. That was done by someone else, and we didn't really have a lot of good integration. We were kind of like waiting on the EHR vendor, but I think everyone realizes what the scope and capabilities of EHR vendors, and as much as they will want to try to be everything to everyone, they're probably getting out of their areas of expertise in some cases. So it's like, what do you do? Do you do something on your own? And so we really wrestled with that in my past. So as you know, we got together, Matt and I and a few others got together to really try to solve this problem. Do you create something on your own? How do you enter the marketplace? So when we listened to all these people and looked at our previous experience, what was being done, we really came up with this Health Next concept, this Health Next platform. So that's sort of what we'll spend the last couple of minutes on, because it addresses most of the remaining questions that I'm seeing. So it's what is sort of a solution set look like? And Matt, you already described some of this, but maybe, and then I'll ask you some questions about it. You described some of this already, but maybe fill in some of the blanks where you didn't. Are you saying that this is like this is a single platform sort of solution, and it's complementary to your EHR?
Yeah, that's exactly what we're saying here, Ed. And also, when we think about a lot of the financial challenges right now between decreased volumes and canceled elective cases, right? A lot of our health system partners are having an integrated solution where you don't have all those hidden costs of putting all that together and maintaining those licenses and maintaining those interfaces. So a single enterprise solution that is integrated with the electronic health record. You and I know all too well not only the financial investment, but the work investment that went into really getting those electronic health records to their current state today, and that ongoing investment in those. We value that. We want to integrate as tightly with that as we can. And so this will the integrated single enterprise platform that can perform multiple capabilities throughout the virtual care spectrum. We talked a lot about telemedicine because that's obviously where a big shift has been in the market, but we also think that's the most a reasonable way to enter this. Now, as we work with health system partners, whatever initiative is important to them, we will certainly make that a priority as well, of what sort of capabilities they want to prioritize. Again, maybe it's something with remote patient monitoring for that at-risk population. Maybe it's a virtual physical therapy, right? That helps with their status post joint replacement patients, helps them manage them in a more effective way. That also is probably easier on the patient, right? Wouldn't you rather have your physical therapy in your living room than actually getting in the car and going somewhere to have it associated with that? So again, throughout the continuum, whether it be telemedicine or whether it be inpatient level care at home, we think we can provide that integrated and on a single platform.
Yeah, so some of the other questions, and I actually touched on it a little bit already, and it's a good question. It really is about, well, can't I use my EMR vendor to do some of this? And my take, but I certainly want to get your opinion, is the issue is they don't really extend beyond the patients that you have. So in true virtual care, I always think about community health and population health. You want a relationship with your community far in advance of them ever needing any of your services. And so this is just this holistic approach that's not confined to specific EMR, or if you end up, adopting this on a platform, the vendors, the EMR vendors may have some what I want to say, nascent solutions in certain areas, but they're not necessarily broad and holistic. And then again, you're still going to end up having pieces and parts. So like senior care and long-term care, very important when you think about wellness for a population and taking care of everyone from cradle to grave. But if they're on different EMRs, because the health systems don't necessarily always own those entities, and so they're on different systems. So you can see that there's always fragmentation, and they don't necessarily do physical therapy. The EMR companies don't do that. And so there's a lot of limitation. Or if the kiosks out in front, and even though kiosks are sort of an old idea, and you wonder, oh, aren't we past kiosks because we go straight to mobile? That's true in many things. But when you want to set up a kiosk like in a school or in an office space that gives you immunity passports and things like that, you're not beholden to a specific EMR vendor, because the people in that mall, the people in the schools, students, they may go to different health systems that have different EMRs. So that's the beauty, I think, of what you're saying, is a single enterprise level platform that then integrates with all the greatness, of the EHRs that are out there. I don't know if you had anything else I kind of went long on that, but if you had anything.
Yeah, no, I love it. I always remember, I'll mention Dan Sullivan's name from Epic. And again, Ed, no one is bigger fans of Epic than you and I are, but Dan would always be whispering in my ear, saying we have 40,000 end users on the hospital side, but we have 1 million end users on the patient population side. So he was so actually Epic was very Dan at Epic was very instrumental in switching my thinking to how do we engage that patient, how do we focus on the patient experience, and not just not an asynchronous e-visit, which was before COVID, which was kind of how they managed this, but not only getting to telemedicine, but again to this longitudinal care and remote patient monitoring and other aspects of this. And we think we can do that, and we can also provide that integration where the docs are going to be working where they normally work.
Yeah, and the other big differentiator that I'll mention, and this isn't meant to be a commercial, but it's just true, and it's something you should think about whether we're talking about virtual care or any other service. This is user designed centric. The EHR, and I love EHRs, no doubt about it. They weren't designed user centric. I think, Matt, you could agree from that from a clinician viewpoint. I can agree from that from everything that I've seen in my career. They didn't come out of the box around journeys of a clinician or journeys of a patient or the patient's family. That's just not how they were designed. Whereas with Health Next, it is designed with user centricity at its core. And then the technology is secondary. It's really about the experience. And I think if we take learning, that's the advantage we have here.
Yep.
So EHR vendors many years ago didn't have the advantage of watching an Apple, as an example, and seeing what the keys to their success were. And then now we've had, virtual care companies have had the advantage of seeing sort of the evolution of some of these other consumer-oriented organizations where it's about the user experience first. And I think that it's going to help with clinician burnout. It's not the solution, but I think it's going to help when you have this user-centric. And then the physical design is key as well. So when we talk about Health Next, it's really about, I hope the first thing that pops in people's mind is physical design, the user centricity, the user experience, because that's what it's all about. The technology, is good, is solid, obviously, but if you don't have the right experience focused, everything else just doesn't matter.
Amen.
So we are down to 30 seconds. Matt, not to put pressure on you, but any closing comments that you have about virtual care or Health Next?
Exciting place, exciting time. Let's take advantage of this collective experience that we've had, not only to be a little kinder and gentler to one another, but let's also take advantage of this to accelerate technology in the way we provide care.
Matt, thank you for being our guest. You're wonderful, as I expected, and it's great to always connect with you. In the last few seconds here, our upcoming webinars, June 18th, more on digital transformation. This is with Suja. She's the Chief Digital Officer of Common Spirit. If you haven't met her before, she's a very lovely person, excellent leader. I've had an opportunity to meet her previously. She comes from outside of healthcare, which is something else we're going to talk about. The Digital Unplugged series part 5 continues. And then finally, July 9th, we're going to take another angle. So in our leadership series, we've had CEOs, we've had CMOs, and now we're going to have a CFO and find out a CFO from Geisinger, kind of his point of view and what's happening and what's going to happen with reimbursement and different things like that. So very exciting time. Thank you, everyone. I know half hour is a lot of time out of your day, but we appreciate it, the fact that you spent it with us. Thank you so much.
Thanks, Ed. Thanks, everyone.